afternoon, everybody. We are basically focusing our discussion on two conditions which are seen in the NICUs. And one of them is very common, all of us have been dealing with it for years together, but there are new insights into that. And the other one is a case which has always existed, but which probably was neglected. So this is entirely a case which is a real-time case. We have just taken two cases which have happened in my NICU, and I have shared with you everything which was done. Some of the things may not be absolutely right. So we have an esteemed panel who are absolutely free to correct us if we have not given what is the right standard of care. We have a very wonderful mixed audience because we have very senior people. Dr. Jayashree is not only a renowned neonatologist, she is the current Dean of Sion Hospital. Dr. Sheila Mathai, I call her Admiral Sheila Mathai. And mixed with experience, we have two youngsters, young Turks, Dr. Satya Bansal and Dr. Vishnu Mohan. So without wasting much time, this is the first case. A typical case in my NICU, a baby called for an emergency C-section because of meconium stent glycoramine. Child was compromised at birth, required some resuscitation. But what was more important was the history. The mother had a very poor obstetric history. With out of 5, 4 babies had died in the neonatal period. There was third degree of consanguinity. There was history of neonatal deaths in other family members also, and developmental delay in one family member's child. So we had a lot of things going on for them. So to be on the safe side, first decision was let's shift the baby to NICU. Baby's weight was 4.2. So that again was another red flag in our findings. Hairy pinna but no dysphoric features. And in the NICU, as is our customary, we did the first blood sugar by glucometry and it was 20. Following the protocol which existed at that time, this was 6 years back, mind you, we gave a bolus of 2 ml per kilogram, 10% dextrose, and I take it up. So, question to Dr. Sheila is, do all macrosomic babies, and we are, Sheila, what I would like to focus is we are dealing with pediatricians who often attend calls in small nursing homes. So in the institute it's okay, shift to the NICU. But to convince an obstetrician to shift to the NICU is a bit difficult. So just babies more than 4 kg, would you shift every baby to an NICU? Would you do sugar monitoring for every baby more than 4 kg? And what sugar glucose levels do we add? And second question is plasma glucose the same as blood glucose? And we gave a glucose bolus. Was that the right thing to do? A lot of questions for you.
Thank you. I think those are very important questions because a macrosomic baby really the worry is hypoglycemia, but all macrosomic babies need not be admitted to an NICU. So what we have to look at is, are there any features of an IDM? Like, are these babies, do they have this florid look? Do they look like small sumo wrestlers? They have a hump of fat at the back of their neck. Their heads look relatively small compared to the rest of their bodies. Their cheeks are absolutely round and red, and they look a little distressed. There may be a little sweating. You rarely see sweating in babies, and hairy pinna. Now, if such a baby is large, more than 4 kgs, obviously you have to keep this baby in the NICU. But if there's a family history, in the sense genetically large babies, term babies with no other risk factors, and previous babies who are absolutely normal, and the babies' heads don't look relatively small, then we could observe these babies with the mothers. And of course, any preterm baby, if the baby is large for gestational age, definitely we should keep the baby in the NICU. What level of glucose? Now, this is a problem. We all know that there are so many.
But one carry-home message for everybody. One level you lack.
One carry-home message is that if there is any risk factor, please admit. But just pure macrosomy without any evidence.
No, about the glucose level.
Glucose, you have to look at one operational level, and if it's a bedside glucose, 40 is the operational level which we take. Plasma glucose is 15% higher than whole blood glucose. So if you're sending to the lab, 45 milligram percent is the cutoff at which you act. And whether you should give a bolus or an infusion, actually we should avoid boluses because they have more side effects and they do more harm than good. So unless the baby is having a seizure or the blood sugar is less than 20, you can give an infusion. You can gradually increase the infusion by monitoring every 15 to 20 minutes.
Thank you, Sheila. So we did exactly what you said, and this is what a summary of what Dr. Sheila said. So this baby, we gave a bolus. At that time, the trend was to give bolus. The sugar improved, but it came up just to 38 milligram percent. We stepped up the GDR to 8 milligram per kilogram. Still, it raised up but still not satisfactory, 43. So we ultimately stepped up to 10 milligram per kilogram. Now is 10 milligram a threshold at which you should do something more, or whether you should just keep on giving 10, 12, 15. We are talking glucose delivery of milligram per kilogram per minute. So question to Dr. Jayashree. So obviously after birth, we know that the mother's maternal glucose supply to the baby is cut off. Yet something happens when the baby manages to be euglycemic or normoglycemic. So could you just elaborate on why, what happens in a normal baby and what is not happening in this baby?
What we need to know is that once the glucose infusion that is being transferred to the baby transplacentally stops, the blood glucose levels actually start to plummet immediately after birth. And the values can be as low as 30 milligram percent. And this generally occurs at the nadir is reached at about 1. By 2 to 3 hours, the baby actually recovers his blood sugar by himself, either spontaneously or because when we do our early initiation of feeding, that also is definitely helpful in bringing the blood sugar levels back to normal. So basically, actually, this is a physiological adaptive process, because now the baby has to get used to, instead of the continuous infusion, a fasting feeding kind of a cycle. And therefore, this is the phase where actually the baby's other systems start getting geared up so that endogenous glucose production is maintained. And these systems are basically, first and foremost, glycogenolysis, second is neoglucogenesis, and third is lipolysis with production of alternative fuels such as ketones, where even the brain can preferentially use ketones and lactate. So this is that whole physiological process. Most of the time it is, we don't even pick it up, we're not even aware of it, unless you're doing a high risk monitoring like Sheila just talked about, and then you find a sugar that is less than 30 milligram percent. And there also we may not intervene immediately, we would give a feed and then see if the baby is responding before labeling it, yes, this baby definitely requires intervention. So that would be, yeah.
Please go.
No, that was the first question.
So we actually, something was wrong, it was not happening. So at 10 milligram per kilogram, we have been taught that now we just don't go on give more glucose. So Dr. Vishnu, is it right? Is there something about 10 milligram per kilogram per minute that we have to think of other strategies? So what exactly do we do, and what is this so-called critical sampling?
So the critical sample, usually a critical sample is the sample taken once there is active hypoglycemia to look into the hormonal responses, and they are obtained when the plasma glucose is less than 50 milligram per deciliter or less than 40 milligram per deciliter when the sample is taken on the bedside in a routine glucometer. So a critical sample should definitely include plasma insulin, C-peptide, a blood pH, bicarbonates, and a sample, urine sample to contain to look for ketones and organic acids. You can also look into the lactate, ammonia, growth hormone, and beta hydroxybutyrate levels too.
Well, at 5 years back, the critical sample which we took 2-3 things. We did a venous blood glucose for lab confirmation. We did a plasma insulin. We did a urine for ketones, and we looked at the cortisol level. So this was whatever available sample or critical sample we could take.
So interpreting the critical sample, usually we can go like with acidemia and without acidemia. If there is no acidemia, things to be considered are hyperinsulinemic states like genetic causes and due to perinatal stress, and other reasons like hypopituitarism and transition neonatal hypoglycemias. If you have increased free fatty acid levels, you can look into the causes like fatty acid oxidation defects. And if it's associated with acidemia, we would need to look into the effects of gluconeogenesis and other factors like glycogen storage diseases, growth hormone deficiency, and cortisol deficiency.
Thank you so much. So these were the other investigations we did along with it just to rule out sepsis. Anything else in this?
Yeah, nothing else. Especially with a history of perinatal depression in this baby, looking to other organ systems too.
My question is, how high GDR can you go up?
So to begin with, we can begin with a GIR of around 6 milligram per kg per minute, and gradually hike on to attain a euglycemic state and use the minimum concentration of glucose required. And
any precautions?
Yeah, the precautions to be kept in mind are the preferred route should be peripheral vein or umbilical venous route. Umbilical arterial route has to be avoided, especially as if the glucose insulation is above the celiac plexus, it can induce hyperinsulinemic state again and resulting in rebound hypoglycemia. And in other than in any other reason, like if you need a GR of more than 12.5 to 15, you need to have a central venous access secured. And rates more than 25 milligram per
Any other
kg.
interventions other than glucose?
So,
So it's just giving glucose and you are sent a critical sample. Anything else you would think of?
you need to initiate feeds as early as possible once the baby is stable.
So this question, obviously, why the critical sample and why the threshold? It means that beyond that, you have to think of a particular diagnosis and you have multiple options. As Dr. Jayeshi said, that the problem could be if there was a substrate deficiency, giving glucose would have helped. So obviously, the counter-regulatory hormones are not working, or you are not getting glucose release. So we have 3 drugs available: glucagon, diazoxide, hydrocortisone. I don't know which one to use. Many years when we were residents, we had only one drug. We used to use hydrocortisone. We used to reach 10 milligram per kilogram, collect a critical sample and give hydrocortisone. More often than not, I don't know whether it worked or not, but we had no other option. So the modern world, when all these things are available, Dr. Satwik, can you please tell us how these different things work? What is diazoxide? Where does it act? Where does glucagon act? And does hydrocortisone have any role whatsoever in your life? Pardon? You want to take us?
Thank you, sir. It's a very important question. Whether we
on this
use
slide?
whether we use hydrocortisone or not. So these are the investigations. Summarizing the case in short, we have a baby who has persistent hypoglycemia. The serum insulin levels are high. The ketones are negative. So if you go by the slide which Dr. Vishnu has shown earlier, we are moving towards a diagnosis of baby with no acidemia and with hyperinsulinemia. So the most common diagnosis in such babies would be hyperinsulinemia, but we are still not sure. So now we have the 3 drugs.
Just interrupt, because the ammonia level, as you all see, is high. But don't get, we also thought that an ammonia in a first sample not collected and in a critical phase can be high. I mean, just for clarification, the audience repeated the ammonia and came down to normal. So the ammonia is normal as far as you know.
Yeah. Thank you, sir. So now in such a case, we have 3 drugs in our hand: glucagon, diazoxide and steroid. So let me talk about glucagon first. Glucagon is actually an emergency drug nowadays. It can be given for emergency management. It can be given by IM and subcutaneous route. The dose is 1 milligram. The another important thing about glucagon is that it has a diagnostic purpose. If sometimes you may see that even in hyperinsulinism cases, the serum insulin level is not detected or is very low in babies. This may be because of metabolism or hemolyzed sample. In such a cases, if you give 1 milligram of glucagon and you see the rise in blood glucose level, if it's more than 30 at around 40 minutes of after giving the dose, it confirms the diagnosis of hyperinsulinism. So it's a diagnostic purpose as well. And the thing is, it's not easily available. So I would recommend that everyone should have a dose of glucagon in their NICUs, because it's now the first line drug in cases of refractory hypoglycemia. Next, diazoxide. Once you have diagnosed that it is hyperinsulinism, diazoxide is your first line drug. It acts on potassium channels, which is the most common cause of mutation in congenital hyperinsulinism. And the dose is 5 to 15 per orally, 8 to 12 hourly. And the major side effects with diazoxide is fluid retention. So it requires concomitant diuretic therapy, and second is hypertrichosis, which is very worrisome for the parents mostly. The good thing is, once your diazoxide has been stopped, the hypertrichosis resolves. Next, a word about steroids. So the bold line on the top: steroids are not an effective therapy for hyperinsulinism. In the past, we have been using steroids left and right, but now with better understanding of pathophysiology of hypoglycemia and also understanding the various side effects which are associated with the steroids, its use has been limited. Still, if you are unsure of the diagnosis, nothing else is working, yes, we do give hydrocortisone, but my word of advice is please send a sample of cortisol before giving hydrocortisone so that you can diagnose whether it's adrenocortical insufficiency that is causing hypoglycemia.
I think one of the reasons people still use it because both glucagon and diazoxide are sometimes just not available. So we now called a pediatric endocrinologist And surprisingly, I have actually taken this from the case papers. When I made this case, I went to a case papers 5 years back, and this is verbatim what she gave a diagnosis. I am very impressed. She said, after writing, this is a congenital hyperinsulinism. This is genetic or familial, obviously because of past history. She said it's autosomal recessive, and the way the child is behaving, she also gave the genetic diagnosis of ABCC8 mutation, which we'll talk later. Now, Dr. Sheila, could you please elaborate on why we now have proven this is hyperinsulinemic hypoglycemia? As Satvik said, probably we would have given high glucose, we did not because we did not have it, and probably it would have proven it, but clinically it looks like hyperinsulinemic. So can you elaborate what types of hyperinsulinemic?
Yeah, so you could have, can I have the next slide please?
One
So you could have a transient hyperinsulinemia, which is seen in many of the common causes of hypoglycemia, and particularly in IVM. We know that the mother's increased hyperglycemia causes the baby's insulin levels to transiently rise, and this can cause hypoglycemia in the baby. Similarly, in a baby with polycythemia, previous slide please, polycythemia, etc. Then you have prolonged hypoglycemia, which is seen in SGA babies, and this is something we tend to forget. So SGA babies actually can continue to have hypoglycemia to up to even 1 to 2 months after birth. So this is something that we have to remember, and we don't know the exact cause, but it is some transient defect in the insulin secretion, and there is a hyperinsulinemia. And then of course you have the persistent hyperglycemias, which are because of congenital genetic causes. As already mentioned, the most common is because of a channelopathy. That is, potassium channels are affected, and there is a persistent hyperpolarization of the cell, which is causing the insulin to be released. You could also have a metabolopathy, which can be because of some problems within the cell, and really there could be a reason of overgrowth syndromes, which can cause hyperglycemia, which we shall talk about a little later.
Thank you. So we started this baby on diazoxide. We reached a maximum GDR of, as I said, 25 milligram per kilogram. We reached a maximum allowable dose of diazoxide. Nothing happened. We were not getting anywhere. There was no sugar. I mean, there's some no sugar, but it was just not acceptable. We are not getting anywhere. We went up to 25 micrograms per kilogram per day of diazoxide. Nowadays, that they say when you can go up to 40. At that time, we were scared to go beyond 50. But baby was tolerating feeds. And now we needed to get this baby of IV. So in the Western country, they would give some polycos or carbohydrates which are slow release. We don't get polycos here. So we actually consulted a pediatric nutritionist in the USA, and she suggested us to give cornstarch. We use that also. So now what? We are really, this was 5 years back, we are stuck. We gave everything which the book told us to do, and we were not getting anywhere. We gave desperately hydrocortisone. Somebody suggested, why don't you use Nifedipine? And also people talk of Octreotide. So Dr. Jayesh, could you talk about, especially about Nifedipine and Octreotide?
So in this case, we know now that this baby has a hyperinsulinism of 65, being the insulin levels when in the face of hypoglycemia. Added on to that, we have this family history where there's so many neonatal deaths. So obviously we're dealing with a case of congenital hyperinsulinism. Now the two common genes which are responsible are the ABCC8 and the KCNJ11, and those are known to be, 50% of those patients are known to be diazoxide non-responsive. So basically here we seem to be dealing with a case which is diazoxide non-responsive, and therefore we have to look at other drugs, because at any cost we have to maintain the blood sugar of this baby, otherwise this baby's CNS is going to get fired, as we all know. So then what are the options? So one possible option is Nifedipine. Now, what is the rationale of using Nifedipine? Basically, the final common pathway for degranulation by the beta cells and the release of insulin is opening of the voltage-gated calcium channels. Nifedipine, as we all know, is a calcium channel blocker. So by giving Nifedipine, we expect that we will prevent the degranulation, and therefore we will help the insulin levels to come down. So theoretically, this sounds very good, but in practice, they have used Nifedipine, and the results have been extremely variable. Most of the places, and there was one very good case series reported from Great Ormond Street, where they found that most of the patients don't respond. You're not even able to come down on the glucose infusion rate, leave alone getting rid of some of the medications, multiple medications that you've used. So it has been tried. Nifedipine doses 0.25 milligram per kilogram starting, and you can gradually scale up to 2.5 milligram per kg per day, but not really very good.
Our case also didn't work at all.
It didn't work, exactly. So the next alternative, you can shift to the next track, is Octreotide. Now, octreotide is considered the second line of management for these congenital hyperinsulinisms. And these days when diazoxide is really tough to get, then octreotide automatically almost becomes the first choice drug. Now, how does octreotide act? It acts at two levels. One is basically the potassium channels, if they remain open and the cell remains in the hyperpolarized state, then the insulin secretion would reduce. So it acts partly on that, like the diazoxide. That is the primary action of diazoxide. But secondarily, octreotide also acts on the voltage-gated calcium channels. And octreotide seems to work very well. I mean, doses have been used in the dose of 5 to 30 microgram per kg 8 hourly. You give it subcutaneously. The only problem is that there are certain adverse effects associated with it. It can cause steatoria, it can cause acute dilatation of the gallbladder, sometimes cholecystitis. Occasional cases of NEC and occasional cases of hepatitis are also being reported. Therefore, one has to be very careful while using it. You need to monitor. And octreotide, as we know, is a somatostatin analog. So if you continue to give it for long, then again, deceleration of growth is very likely to occur. So these are some of the things that we have to keep in mind. But yes, definitely in this baby, since diazoxide, the patient was non-responsive, octreotide would have been the next choice to treat.
Okay. Panelists, I request you to be a bit quick because we don't have time. We just have 5 minutes to finish this case because so Dr. Sir, a very important point. We know everybody said that this is genetic. So how, though we are neurologists, we don't want to go into the nitty-gritty of genetics, but what sort of a genetic counseling or what sort of a genetic-wise oriented testing we should do? Can you please?
So I'll be very brief, but the most important thing is why genetics right now. Right now our main focus is management of the baby. So genetics in this case is important because genetics defines or will help us to decide on the histological subtype of the disease, and that histological subtype will further lead to our change in management strategies. So what is recommended is to get the most common gene tested, that is ABCC8, KCNJ11 gene tested. There are 3 possibilities that can arise. Possibility 1, if there is a biallelic mutation, be it homozygous or heterozygous, if that's there, you can straight away consider it to be a diffuse form and will be managed according to it. If there is no ABCC8 or KCNJ11 gene mutation, or if there is a paternal uriparental disomy, that is the allele that is distorted is of paternal variant, and the maternal variant there is no allele and it's been subdued. So in this case and in the no mutations in both these cases, you can have a focal disease as well. So you need a further imaging by PET scan, and then you can decide whether it's a diffuse form and focal form and diagnose and treat according to it.
Thank you.
The other thing is, how do you counsel the parents? Again, there are 4 situations. If it's a de novo mutation or a sporadic mutation, the risk of recurrence is almost null. If it's a focal form, again the risk of recurrence is very negligible. However, in a diffuse form of disease or in non-identification of the causative agent, the rate of recurrence can vary between 25 to 50% depending on the inheritance that you are expecting.
I think we'll skip the next one about the syndromes. But we still with this got an erratic but insistent response to hydrocortisone Nifedipine, and 24 hours after starting Octreotide, we suddenly saw that we could get down the sugar, and we could gradually get down this sugar. So basically, we have always talked about the Octreotide mechanism. So, Dr. Vishnu, can you tell us now? Dr. Sathya mentioned about imaging. What is the role of imaging in this patient?
Yeah, the imaging modality of choice in a baby like this with persistent hypoglycemia would be FDOPA PET scan along with an enhanced CT scan. So the advantage of FDOPA PET scan is it helps us identify whether the pancreatic pathology is a diffuse one or a focal one. But the negative aspect being it is hardly available in any centers in our part of the country. And again, it is less accurately identifies the location of and the size of the lesion and doesn't aid much in the pancreatic resection.
So this was happened to our patient. Went on full feed, we added cauliflower as a source of starch. We continued diazoxide, gave Octreotide, sugar started getting accepted. We tried to train the mother to give Octreotide subcutaneously 6 hourly. That time there was no PET scan facility in Pune, so we sent to Bombay for a We sent them for a DOPA PET scan, but we came to know it was not available. So we got Octreotide PET scan, which showed a diffuse type of pathology, but not confusing. We told the parents that we could possibly offer surgery. So, Dr. Sheila, could you please tell us, does what finding on the PET scan is helps you in a surgical manner? I can ask you to brief here.
Yeah, so can I have the next slide, please? So if it is a diffuse type, then the prognosis is bad. Even if you do a near total pancreatectomy, this is not going to solve the problem of the hypoglycemia. But if it is focal on the PET scan, then you could suggest that this child could have a subtotal pancreatectomy, and this is near curative. So that's the main thing that we need to remember. And if it is focal, as we already mentioned, it is a particular subtype which has been inherited from the father. But we don't want to go into the genetics of that.
So we offered the parents subtotal pancreatectomy because we didn't assure them. They opted out of it. They said we'll take lifelong subcutaneous Octreotide. This child is now 5 to 6 years old, going to a school. Mother gives Octreotide subcutaneous injection. He's a poor farmer from Nagar. We have managed to get everything free of cost for him. And the report from UK. The problem with the reporting, what Satvik said, is that if the report helps you in diagnosis, our report came 4 months afterwards because we had to send it to UK. And about everybody said on the panel, it turned out to be that ABCC8 gene nonsense mutation. Second case, again a common NICU case, but I would like to focus on a factor which is not very thought of. Typical run-of-the-mill case, male baby, preterm baby, 28 weeks of birth weight 750, it's not 75. NICU admission, day one, as per our policy, we have started trophic feeds. We are very aggressive with TPN in our unit, more so because now we've got a young neonatologist there. We put this child on caffeine. And day 7, there's central apnea, baby was ventilated, HB was okay, nothing's great. Baby had NEC stage 2B, so usually I kept NB for 7 days, again TPN, again antibiotics, caffeine continued. And everything was settled down, but we could not extubate this baby. 3 weeks down the line, we just could not. So normally we think of BPD, we think of PDA, we think of sepsis, we think of IVH, we ruled out everything. But we just could not extubate the baby. It was fine, active. And then, that's what I tell you. Sometimes we see a patient from far and we think, but sometimes we see the patient close up. And this is when we took a photograph of this patient, this is how the patient looks. Yeah. Now everything seems very common. It looks like the child is having rickets. But so this, when you see the baby on a ventilator, you hardly notice this. So somebody said this is metabolic bone disease. So I would ask Satvik that what is metabolic bone disease? And there are so many things like we say osteomalacia, osteomalacia, rickets, osteoporosis. Are all these terms interchangeable? Or what is the difference? Dr. Satvik, please.
Thank you, sir, for this important question. Even I was very confused in my postgraduate days as to why it's called rickets of prematurity and it's also called as osteopenia of prematurity when both these things are different. So what actually is difference is the bone has 2 parts. One is the organic part and one is the inorganic part. The organic is the protein matrix and composed of cells and collagen, and the inorganic part is composed of your minerals like calcium and phosphate. So coming on to the definitions, so what we call as metabolic bone disease is can be defined as decreased bone mineral content. It can be decreased bone mineral content in an absolute manner, that there is lack of mineralization. It can be a decreased bone mineral content in a relative manner. That means relative to the osteoid or the organic matrix, the mineralization is normal. But since the osteoid is itself less, the mineralization is less and the mineral content is less. So it can be both. Hence, we can call it as both as rickets and osteopenia. Now what's osteomalacia? Osteomalacia is lack of absolute mineralization. Your osteoid or the organic matrix is normal, but your mineral content is abnormal. And when this lack of mineralization affects the growth plate, it's called as rickets. Coming to osteopenia, it's the decrease in the amount of organic bone matrix. The important thing to note is matrix remains normally mineralized, but the mineral content is less. Osteoporosis is a severe form of osteopenia when it becomes associated with pathological or atraumatic fractures. In adults, it's defined as a bone mineral density below 2.5 standard deviation. There is no acceptable definition as of now in infants and newborns.
Thank you so much. So, Vishnu, this is the important question which all neurologists should know. What are exactly the risk factors for metabolic bone disease? And all of them were in our case. So, can you tell us?
Thank you, sir, for that important question. So, looking into the risk factors, most common and important is prematurity and low birth weight. And other risk factors include babies who require parenteral nutrition for more than 4 weeks, babies with bronchopulmonary dysplasia being treated with loop diuretics and fluid restriction, the ones on long-term postnatal corticosteroids, babies with history of necrotizing enterocolitis and requiring surgical treatments, and all other babies who has any abdominal pathologies and require surgeries, and other babies like failure to tolerate formulas and human milk which are fortified with high mineral content.
How common is it?
And looking into the incidence of metabolic bone disease, it's like inversely proportional to the gestational age and the weight of the baby. As the weight and the gestational age decreases, the incidence increases. So since the era of preterm formulas and fortifiers have come, the incidence have come down significantly from around 50% to near to 10 to 20% now.
Sheila.
Yeah, so this is the problem about the clinical features. We don't really see them early because the features of rickets are seen in growing bones, and the preterm babies take time to start growing. So the features of metabolic bone disease, the clinical features are really very, very subtle. You may have a widely open anterior fontanelle or widely open sutures, but by and large maybe just failure to thrive, irritability, or most important, the baby just can't come off the ventilator and you just don't know what is the problem. Sometimes you may get swellings and deformities, fractures, pain or tenderness, but by and large only when the baby actually starts growing that you see these frank features of rickets.
How does one diagnose?
So what you have to do is to look at the biochemical and the X-ray features, which will be discussed later.
Since Dr. Sheila has talked about clinical, can I hand over to Dr. Jayesh to tell us what we all of us do calcium, we do phosphorus, we do alkaline phosphatase, but what is it which really defines metabolic bone disease?
Basically,
could you talk about X-rays first?
You want me to talk about X-rays first? Yeah, fine. So, one of the issues that I've been asked to address is what is the role of X-rays in diagnosing metabolic bone disease? So basically, I mean, we heard all those 4 definitions just now in the beginning about all those various. So basically, it's a spectrum of the same disease. I mean, also age-wise and this thing, it's a spectrum of the same disease. Now, when we talk about radiological changes in metabolic bone disease, one thing that we have to remember is that radiological changes come up much later. Almost 20 to 40% of the bone demineralization has to occur before radiological changes are actually evident. And these radiological changes are basically thinning of the cortex, so the bones appear washed out. You may see some amount of periosteal reaction. A little advanced, you'll see rickets, and worst case scenario, you may actually see fractures. Now, Cohen way back in 1989 actually, to go back to the previous slide, classified it similar to what I just said, that if you see fractures, it would be grade 3, if you see rickets, it's grade 2, and if you see this thing, that would be grade 1. Now, next slide. What is the lab parameter? Now, basically, it's all about prevention of metabolic bone disease from occurring, and therefore and since, like Sheila said, you're not going to be able to pick up the clinical signs soon. So therefore, basically, it's a biochemical monitoring that is required. The biochemical monitoring, you do what is called a bone profile, which includes calcium, phosphorus, and alkaline phosphatase. But remember that calcium doesn't really tell you anything, because that parathormone is always going to keep those calcium levels going at whatever cost. So the parameter which is the most sensitive and which tells you that yes, this baby has metabolic bone disease is basically the serum phosphorus levels and to an extent the alkaline phosphatase. Now the serum phosphorus levels normally should be above 5.6 milligram per dl. Values lower than that are called hypophosphatemia. What studies have shown is when you use a combination of a serum phosphorus less than 4.6 milligram per dl and an alkaline phosphatase. Again, we know that because growing bones, so some amount of alkaline phosphatase in newborns and particular preterms is going to be higher. So 5 to 600 it normally plateaus and you don't really give it too much worry. But when it's above 800, so the combination of alkaline phosphatase alkaline phosphate is greater than 900 and your phosphorus less than 4.6 is definitely an important parameter.
Satvik, briefly just give us, people we don't know what Xrays is, just tell us in 4 lines.
Nowadays the upcoming thing is DEXA. DEXA is dual energy X-ray absorptiometry. It's considered the gold standard for diagnosing metabolic bone disease. It is the more important, the major advantage is that you get to know about the bone mineral content, the bone mineral density. Also, you can predict fractures, which, as we have already discussed in X-ray, it takes a lot of time before you get some findings on an X-ray. Also, there is some data now for terms and preterm babies. The major disadvantage is use of ionizing radiation, logistic issues because it's a mobile machine, so for transporting unstable newborns or newborns who are on ventilator, movement artifacts, if a baby moves then the entire reading goes haywire. The lack of data for determining which skeletal sites are optimal to determine the fracture risk and to identify diseases is still under considerations. So we still need we have a long way to go.
Satvik, just 2 lines
Next,
on
quantitative ultrasonography, it's a research modality. It's also, we do common measurements like speed of sound and bone transmission time. The major advantage of this modality is that there is no ionizing radiations involved, and it's portable, cheap, and can be used easily. The disadvantage is we do not have any data, and it is still a research tool, so we need to see how it goes.
Vishnu, 1 line. When and how should one screen? Dr. Joshi already talked about it, but
so screening is ongoing. You should ideally start screening at 4 weeks of life. And the things that we use to screen is serum phosphorus and alkaline phosphatase activity. So the next slide. So initially the alkaline phosphatase values peaked at 400 to 800 international units, and then it falls to around 500 in a normal baby who doesn't have rickets. If the alkaline phosphatase values are greater than 1000 international units, and along with X-ray changes, as Madam explained, those are confirmative rickets.
Sheila, now just the important thing what you would like to tell them about parental nutrition and...
So parental intake of calcium is lesser than the oral intake. So when we're looking at parental calcium, we're looking at 80 to 120 milligram per kg per day, and the phosphate requirements are about 2/3 of that. We should maintain a calcium to phosphorus ratio between 1.7 to 2.2. And in India, we do have a problem with phosphates. It's not that they've just recently become available in the market as potassium phosphates, but they are not compatible with the calcium gluconate. So when we are making the parenteral nutrition, either we can give the calcium or we can give the phosphates. We can't put both together into the same solution. So it doesn't help us. So this is a major problem in India with prolonged parenteral nutrition in newborns. And so we should try and put them on oral phosphate supplementation with fortifiers, etc. as soon as possible.
Jai Shri, a topic very close to your heart, but please just give us the gist of...
Okay, let's talk about the requirements of calcium and phosphorus. Minimum, I mean, A, B and as can give you totally different requirements of calcium, phosphorus and vitamin D. So we'll take the middle path, about 100 to 150 milligrams of calcium per milligram per kilogram per day of calcium, around 75 to 100 milligram per kg per day of phosphorus, keeping the ratio roughly 2:1. So the whole idea is actually to give it through fortification of breast milk. Now, if we look at the commercial fortifier which is available, if we were to fully fortify the breast milk, then what would happen is that when we give about around 170 to 180 cc's per kg, we would be able to provide enough calcium and phosphorus for a growing preterm baby to avoid metabolic bone disease. But the only issue in this is that what happens is, let's say that you require let's say even 150 ml per kilogram, and it's a 1.5 kilo baby. So 225 cc's, that means they are going to require almost 8 to 10 sachets per day. Now each sachet costs 22 rupees 50 paisa. So therefore, full fortification may not always be possible because the parents can't afford it. So one thing is to check the history and see that whether full fortification is done. If that is done, then the calcium, phosphorus and vitamin D requirements all are met. If that is not possible, then direct mineral supplementation is required, and the direct mineral supplementation, you need to know what market preparations are and what is the ratio in which it is available, and choose and then calculate the total requirement. Can you just go back to the previous slide? The first line will show you the normal requirements, like we said, about 150 milligram per kg per day of calcium is what we want to roughly give them, and half of that is hospice. Thank you.
Thank you, that was really fast, Joshi. So, coming to the last two slides, just name some drugs in the NICU which contribute to metabolic.
So ironically, these babies are preterm babies who require long-term support, and most of the medicines which are used in these babies can contribute to osteopenia, like methylxanthines, your caffeine, diuretics, also steroids which can be given, which is generally used for BPD. Antenatal glucocorticoids can also be a reason, and antenatal magnesium which is given for preterm births can also be an additive agent for this. Lastly, anti-epileptics like phenytoin and phenobarbital also are a risk.
Vishnu last, what has physical activity of the baby, keeping the baby seated, in the NICU inactive and on ventilator to contribute to it?
Physical activity, actually, there are evidences that physical activity improves the short gain, weight gain of the baby, but there is nothing concrete to suggest that it improves in the long term.
I'll just summarize the key messages. All neonates have high relative requirement, and we talk of surfactant, we talk of the other things, we just forget the minerals. They require high minerals, and the risk of metabolic bone disease is more smaller the baby, and inadvertently those are babies requiring great intervention. So home health is a critical concern, and if you want to prevent, you must go to enteral feeding as soon as possible. Please fortify the milk. When you have TPN, ensure that you have the right preparations, and biochemical monitoring should be done. You should be provided, some people say give 400 units, some give 800 units, but at least give 400 units per day to every baby. Minimize the risk factors and keep the baby moved tight and allow passive stimulation. Thank you very much.